Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy You, Healthy Nation, and Healthy World. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And we have a wonderful guest here today, Nurse Grace Woomer, who is the Director of Patient Care Coordination at Mainline Health. And she has a really interesting job that she's going to tell us about today, because what she is doing is she's inventing the future of healthcare as you will be experiencing it. And she's going to explain what she's doing at Mainline Health and how that is going to afford you a superior patient experience if indeed you, a family member, a friend, a colleague, excuse me, are at Mainline Health. So our title today is Transitions in Care. And she's going to tell us what it means, what it does, and where we're going to be able to find it in the future. So let me tell you a little bit about our guest, Grace Woomer. Thank you, Grace, for being here.
Thank you,
and
Nancy.
I want to tell you about Grace's background, because as you have heard in some of our other shows, we often have nurses who started out in other fields, and Grace is another example of that. She started out in chemistry and biology at Fairleigh Dickinson University, and then I'm going to let her tell you why she made a left-hand turn and decided to move into nursing, where she got her bachelor's degree at Seton Hall, and then she went on to Villanova and got her master's degree. Her background is in rehab and home care, and we are delighted to have her with us because she's a very seasoned professional with a lot of experience to share with us. So Grace, thanks for being with us.
Thank you, Nancy.
So let's hear your story about how you decided to go from that chemistry and biology into nursing.
Well, it was an interesting experience. Again, through biology and chemistry, I was afforded some other classes, and one was bioethics. And they were all situational. The situation was you were pretending to be a nurse of an 88-year-old patient who was recently diagnosed with cancer. The family knew that the patient was diagnosed with cancer, but the 88-year-old did not. The family asked the physician not to tell the 88-year-old because they thought that she would be upset. You're the nurse in the hospital, and the doctor writes on the orders, do not tell the patient their diagnosis. You go into the patient's room, the patient grabs your hand and says, "Nurse, I know something's wrong with me. Please tell me what it is. What do you do?" And of course I say, "Well, you tell the patient." And the bioethics teacher said, "In this circumstance, you can't tell the patient that because the doctor wrote the order and the nurse needs to follow the physician orders." And I thought that was terrible, and I thought I should change nursing and move into that field to be able to have a patient-centered approach to what nurses do. Luckily, by the time I graduated from my Seton Hall experience, that was already taken care of by one of our presidents back in that day. And now we have patient rights, and that cannot be done.
Mm-hmm. Well, it's good that they certainly got you to go into nursing anyway, because you're still changing nursing by the work you're doing today. So, I mean, you really are doing a lot of patient advocacy work nonetheless. So it doesn't sound like it was a bad decision.
It's been one of the best decisions of my life.
That's wonderful. Well, Grace, let's start from where we are today. You know, we've heard about Obamacare, we've heard about the Affordable Care Act, but you are in a position where you are translating that policy into practice. So tell us about the policy and what you're learning as you are putting this into place.
First of all, there's a disclaimer that I am not an expert on the Affordable Care Act, but I will tell you that the pieces that relate to what I do in transitions of care, I can speak to. There are 2 areas in the Affordable Care Act that, if you look at it, there are many sections to it, or titles. And then under those are subtitles, and under them there are more parts and then sections. The pieces that I put into place, and everybody knows the first title, it's all about coverage universal coverage, and of course everybody knows that because it's been in the news. If you knock down to the third title, that's about transition, where I kind of live in my work, in transitions of care. And let's explain what transitions of care is. Transitions of care is just defined as moving from one healthcare provider or place to another, whether it be physician to hospital, hospital to nursing home to rehab, rehab to home health, back to physician. So all of those are transitions. Where we see the gaps in healthcare are not actually in the care of each of those silos, if you will, but bridging those with the information from one area to another. So that's where I do a lot of my work.
Now, can I just stop you there? I mean, in terms of transitions in care, I mean, those examples are really what people have experienced. So they've been in acute care, they've been moved to a nursing home, or they've been discharged to home, or they've been discharged to a rehab. So tell us in detail, if you can, what is different now? Because people have been transitioning all along. So the fact that this policy document is articulating these transitions in care, what is it hoping to achieve?
The transitions in that the Affordable Care Act is trying to force health systems to look innovatively at different models of care, including transitions of care. They have actually created in the Act, it is that they will create a Center for Medicare and Medicaid Innovation. The acronym for that is CMMI. CMMI has many different innovative projects. Last time I looked, and this is an ever-changing field, there were 41 different projects that they were looking for healthcare systems to implement. They call them demonstration projects. One is bundle payments. Bundle payments is what I spend a lot of time on, meaning they're looking at a 90-day period of time, not just the time you're spent in the hospital, but 90 days after that. It's very exciting, and it's requiring a lot of these post-acute providers, as we call them, providers that touch you after you leave the hospital, to start talking together. And that is actually innovative, believe it or not. That is actually something that we have not done well in the past, and we need to move on going forward.
Well, I think that anyone that has been in acute care and then had all these other episodes of care in some of these other parts of the healthcare system, as I mentioned earlier, whether it was rehab or home, and once they get their bills, that's when they see in vivid living reality how each organizational entity bills separately for these services. So part of what I hear you saying is that somebody's going to have to look at this person's care over a 90-day period of time, and they're going to have to organize how that care is going to be delivered and make sure that it's not all separated out as different episodes of care. Is that what you're telling us?
That's correct. And the biggest push with bundle payments, and another piece of the Act, which is readmission penalties, is for those patients that can stay away from the hospitals to stay away from the hospitals. In other words, avoidable readmissions. Certainly readmissions to the hospital occur all the time for very valid reasons. What we're trying to prevent is, if we had good care coordination between those buckets, if you will, or silos, that information transfer, patients would be able to stay safely in their environments without being readmitted. And that, again, is an exact byproduct of the Affordable Care Act, with the readmission penalties.
So in the Act itself, it really describes what the goals and objectives are, as well as gives some money to help different places, do some very innovative things. You've already mentioned that there's really some startup money, so to speak.
There is funding, correct.
To be funding. But the funding for healthcare overall is really going to change in a good way.
Yes.
What you're saying is that people are going to have so much money for a particular illness, and that healthcare organization is going to have to manage it over that 90-day period of time.
That seems to be what the demonstration project is looking at. Now, with all demonstration projects, they evaluate how well you have done with that project versus another one. And yes, well, most likely we believe this will change how providers are being paid, and for most likely longer periods of time.
So they're giving healthcare organizations an opportunity to ramp up and to experiment and to have an opportunity to sort of do some trial and error learning, because this is a very complicated change. And because it is so complicated and there are real people involved, you know, patients, and nobody wants to see them at risk, a lot of this is being organized in a way that we can look at the outcomes of that and then judge and answer the question, can it be done, you know, successfully? Can it be coordinated? Can it be paid for in that bundled payment, that term that you used? And can people get better? I mean, better sooner, stay out of the hospital and stabilize. I mean, that really is, I think, an overarching goal of this part of the Act. Would you agree?
That's absolutely right.
Okay. So having that very basic understanding that Grace has really been helping us to understand, like the ABCs of a very complicated document and a very complicated policy change, she's then taken on the job of actually trying to make this translation at Mainline Health. You're a very brave woman, because you've got a lot of people to deal with.
Yes, bravery has never been something that I shied away from. Actually, it's been lovely. Quite frankly, everyone is on the same page. Everyone really believes that a patient-centered approach is the way to go. What they don't understand is how to make that happen. And that's really what I'm doing, is trying to coordinate, bring people to the table, have discussions, being honest about how to be patient-centered and move that through. It really is the physicians, the nurses, the people in the finance office, the people in the information area, information systems, we're all there for the same thing. If we weren't, we wouldn't be in healthcare. Again, it's understanding how do we talk to one another, what's the best way, and moving it through.
Well, it is a vast assignment. I mean, there is no doubt about it, and I'm glad they picked someone that, you know, like you say, bravery isn't something that you have a problem with. It. You know, you've got that really strong bravery DNA thread, which we need. I mean, we need people that are really going to step up and really take some risks. So in the course of a day, as you're getting these different people together, just give us a flavor of some of those conversations. I mean, how do you get people sort of moving in the right direction?
If you show, especially I'll talk about what I hear as a slight change in the dialogue, as you get physicians and nurses, respiratory therapists, all different types of clinicians, physical therapists at the table, show them just some information, some data, interpret the data. You will see a shift in how they're thinking. For instance, for some of our conditions that we're looking at for this project, many of the dollars are spent in the post-acute arena. I don't think some of the folks at the table ever thought of the dollars associated with the post-acute dollars for Medicare.
Just to translate post-acute, for not everybody would know what that term means.
So post-acute for us means those dollars that are spent on home health, on rehabilitation hospitals, on skilled nursing facilities, or some people will call them nursing homes. Those dollars account for a large percentage of what Medicare puts out after you go to the hospital. Once you illustrate to the providers at the table, the healthcare providers at the table from the hospital standpoint, how many dollars are spent in that area, it's been an aha moment for them. And then they want to know, well, what's the quality of what's the quality of that nursing home? What's the quality of that home health provider? Things that they may have thought in the background, perhaps, but now it's coming to the front of the table. And they're saying, maybe I better maybe I better be more aware of that. I also hear other transformative conversations, if you will, around the actual practice once you are in the hospital. We used to call it the art of nursing, right? I'd wrap a leg one way, you'd wrap a leg another way. Well, actually, there's a best practice to wrap that leg.
Right.
So what we're charging our physicians with is getting them together in a room and saying, what's the best practice for this patient, and implementing that best practice and making sure they're held accountable to continue that best practice while they're in the hospital. It could be a variety of things. Those conversations are very interesting. The other day, a physician said, I just never thought that there was a better way to do that. Thank you. And he was thanking another physician related to anesthesia. And it was something that maybe we've never heard before. So he really was very thoughtful, open to change, and he probably didn't understand how excited I was inside to hear the change.
Well, I think part of why you should be excited is you're helping to facilitate that conversation. So
Right.
that alone is exciting. I mean, you're really helping people to really gain a new vision of their everyday work. I think the second thing that you just said about that is that there are best practices. The art and science of medicine, the art and science of nursing is really now moving really into the real science-based approach to do anything. It's not as complicated as what is the best approach to doing heart surgery. For nurses, it's the best approach to bandaging something, or how to take care of an IV properly. There are all these different science-based approaches. And part of what is also known is that there's a lag in getting this dissemination of all of these best practices out to all the physicians, all the nurses. I mean, there's always a gap in any field between the knowledge and the actual practice. But in a very interesting way, from a policy perspective, the Affordable Care Act is really pressing on everyone to have those conversations.
Absolutely.
Because before there was the Accountable Care Act, there was no need to have it. Everybody sort of worked in their own track. If you were acute care, you were working in a hospital. If you were home care, you were working in the community. If you were in rehab, you were working in a rehab hospital. And what we really were hoping and depending upon is that someone would coordinate that care. Often it was your primary care physician, but often in those situations that wasn't happening either. So at the end of the day, if the truth be known, no one was really coordinating the care. So you were getting two really unhealthy outcomes. First of all, people were not necessarily getting the best outcomes for their own care. They may be getting very good care. It wasn't that they weren't getting expert care and expert attention, but if you're not coordinating it, a lot of things can fall through the cracks, right? From a just a day-to-day
That's correct.
perspective. So that's happening. The second thing is that it is very expensive, because if the left hand isn't necessarily talking about the right hand and people are billing for all these separate services, the bills get very big very quickly. So I think that what you're telling us is that by facilitating these very early conversations and really having people understand that not only is there pressure to do this, from a health perspective, from the Accountable Care Act, again, externally from the policies that they are now living under, there is also the desire to do the best thing for the client. And once they start saying, gosh, maybe there is a better way to do this, it can get actually quite exciting, right?
Absolutely. Absolutely. It's every day I come into work, I'm happy to be doing what I'm doing, because I really live and believe it. I worked in hospitals, I worked in rehab centers, and I worked in home care. And my own parents are 91 and 88. And I need to get this right for them, but I need to get this right for everyone. So it's something that's very personal for me, and exciting as well. So as we move forward, we are looking for some of those gaps to go away. In what we're working on is the transference of information that can be moved from one location to another. And that sounds easy, Nancy, but it is not easy. When you think of all of the information systems that have to talk to one another, you almost need a translator. And different levels of care have different abilities. You won't get the same kind of care in a nursing home that you get in a hospital and vice versa. You won't get the same care in home care that you get in a hospital. But there are different levels of care, so we're trying to put the patient at the right level of care at the right time.
Right. So it's like the three bears. They don't need too much care.
Right.
Sometimes,
Right.
and they certainly don't need too little.
Right.
And you're just trying to get it just
right.
Okay, so that's a very worthy.
Sometimes I do feel like Goldilocks.
And you sort of look like Goldilocks with that hairdo. You look great. Well, this is all well and good. I can just imagine that some people are thinking, well, that's interesting. I'm glad that Grace likes her job and that she's getting people to the table to talk and that the organizations are starting to, knit this whole thing together. But, sort of what's in it for me and how am I even going to understand it? I mean, what would the consumer see differently? If not right this minute, what do they have to look forward to?
Well, I think for right now, what the consumer should understand is that they shouldn't take anything for granted. That if they're moving from one level of care to another, they should be asking questions. Who is going to get this information? How are you going to give it to them? And to make sure that your information goes over. Now, if you're sick in a hospital bed, my recommendation is to have someone there with you when you're talking about moving to that next level of care. There's a lot of information, there's a lot to go over, and you need another set of eyes and ears to interpret what nursing is telling you or a physician is telling you. So that would be my recommendation to all consumers. Many programs now, you hear the word nurse navigator, you hear those terms. Those may be afforded to you. If they are, use them. Other communities use health buddies or coaches or health coaches. If that's afforded to you, use that. It's of no cost to you, and it really will help you move through those transitions of care and help you interpret if you didn't really understand what was said to you when you were discharged from the hospital. So I would always suggest that you follow up with one of those programs. The other thing is don't be afraid to ask questions. If you don't understand what is being presented to you at the time, it's okay to say, I'm very tired right now, can you please come back? Or can you repeat that one more time? Just make sure that you're repeating back what that person says so that they know that you understand. A lot of this is communication. It's all about communication. And you have the right as the patient to be talked to in language that you understand. And if you don't understand it, it is not any reflection on you. It's a reflection most likely of how we're talking to you. So it's okay to ask questions. We say questioning mind, and no one will be offended that you're asking. In fact, they'll probably be very happy that you're clarifying what they're telling you.
Right. So I think that's very good advice. And we're hearing that from a lot of our presenters, that for your involvement, is to really feel like you are a partner, that you are not just someone that's going to sit there quietly and just wait for things to happen to you or to your loved one, but that you can engage, in a very meaningful way. So when is this all going to happen? What's your prediction for the timelines for all of this?
Oh, if I knew that, I would go and play the lottery. My father is a retired harbor pilot. And my analogy is you're out on the largest steamship in the ocean, and it's a very choppy ride because there's a lot of storms coming. So imagine a steamship going full steam ahead, and you get a call that you have to reverse course. It takes a really long time to turn that steamship around, right?
Right.
You have to slow it down first, and then you have to start pivoting, and all the while, water is hitting you. So I'm not going to predict. I'm sorry, Nancy. But I must say that we're slowing it down, and we're almost at the point of turning. It will take years. To change a culture, it takes years. So my suggestion is do your homework, don't be passive, And we will change it. If the conversations that I'm hearing are the conversations that will continue, we will change this, and we will be able to move seamlessly through these levels of care. I'm very excited about information technology. You'll see physicians now using iPads and iPhones and other electronic devices. If we can get that all on one platform, we have a lot to look forward to,
right,
as far as information systems and technology.
So let's talk a little bit about those information systems, since, like you mentioned earlier, data is very important. And not only do you need people to coordinate some of this care, but you actually need the information in order to do it properly. Mm-hmm. What's happening in that area? How are these information systems, as you mentioned earlier, they're very different in different places. Do you have any thoughts on how that is going to get knitted together?
There is, again, part of the Affordable Care, actually it's probably not part of the Affordable Care Act, it's another act, and forgive me for not remembering. The ARRA, the Reinvestment Act, known as the Reinvestment Act.
Right, right.
Part
but
of that,
it was all intended to work together.
Part of that deals with information systems. And again, another policy helping us to fund what we need to do from an information technology standpoint to have at least compatible systems, or they call that meaningful use. How do we work through these systems to make it meaningful for all providers? There's great promise there. I can't speak to that. I think that would probably be a whole nother session for you.
Probably would be.
Bring in some folks. That. But what I see from the folks that I deal with every day, both in, they call it analytics, data analytics, informatics, and information systems. There are 3 different groups. When they get together, it's powerful, and they can pull a lot of information and help us to identify who may be at risk for a rehospitalization and where we need to put our resources. So talk about efficiencies. Instead of doing the same thing for everybody, we concentrate on a certain population, and we will help them to stay well, hopefully where they want to be.
Right. I think this is a very good conversation. It's a beginning conversation with a big change, as Grace said. It's going to take, a decade or more to really make it all happen. But the wheels are moving, and when you get really smart people together to really have those conversations, things start to move more quickly than not, because then everybody's invested in doing the right thing and wanting to do it better. So I would say that when you decided from that ethics course all those years ago to say, I'm going to get into nursing and change it, I am delighted to see that you've got a role where you're really front and center and you're doing just that. Maybe from a different point of view than you thought you might be doing from an ethics perspective, but you're doing it now in a way that is really changing the whole infrastructure of the healthcare system. Are there any other tips in closing that you want to give to our viewers? Anything that you think would help them?
Stay informed. There is, whether it be reading the paper, getting on your iPhone if you have one, listening to the local news, stay informed, and again, take opportunity to slow it down a bit. Slow your own ship down a little bit. When you're in a situation where you don't understand your healthcare provider, and ask questions. That is the best medicine. And follow all those healthy tips to stay out of the hospital.
To begin with. Right. Well, I'll definitely underscore that. But I think that what I really appreciate from Grace's discussion with us today is that we often hear so much negativity about the Affordable Care Act. We hear the hype and all the doom and gloom about it. But, she's inside the tank and she's working it through. And there are some very good parts of it that really are going to make masterful changes that are really long overdue for the healthcare system. So I think that you got a taste of what that has in store for you. as a user of the healthcare system, and I hope that you have found this to be helpful and informative. And I want to thank Grace again for being our guest, and also want to say, I really appreciate that you're at Mainline Health and you're doing such a great job. Thanks again.
Thank you, Nancy.
You're welcome. And thanks for being with us. Have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.